Hi, good morning, doctors. Today we are going to read the topic chronic heart failure, page number 232. We'll continue on the sixth day of our reading of Oxford Handbook of General Practice. Chronic heart failure. Chronic heart failure occurs when output of the heart is inadequate to meet the body needs. It is the end stage of all the diseases of the heart. Nine, nine, 9 lakh people in the UK have heart failure. Prevalence increases with age. Acute heart failure, page 1068. Causes of chronic heart failure. High output. The heart is working at normal or increased rate, but the needs of the body are increased beyond that which the heart can supply. Example, in cases of hypothyroidism, anemia, Paget's disease, and AB malformations. So these are high output heart failures. Low output heart failure, that is decrease in heart function. Either it could be an increase in preload, example mitral regurgitation or fluid overload, or a pump failure. Cardiac muscle diseases like ischemic heart disease, 46% of the cases, cardiomyopathy, decrease in expansion of the heart and restricted filling like in restrictive cardiomyopathy, constrictive pericarditis tamponade, inadequate heart rate like beta blockers, heart block, post-MI, arrhythmias, atrial fibrillation is the most common. Decrease in power, negatively inotropic drugs, example verapamil and diltiazem. Chronic excessive afterload, increase in BP or aortic stenosis. Presentation. See, preload is anything before the wall and afterload is anything after the aortic wall. Presentation. Clinical diagnosis is difficult. Take a detailed history and do a clinical examination to exclude other disorders. Algorithm for diagnosis of heart failure we'll see in figure 9.2. Differential diagnosis. Obesity. So, differential diagnosis for heart failure. This is obesity, respiratory disease, venous insufficiency in the lower limbs, drug-induced ankle swelling, example calcium channel blockers, or fluid retention, example NSAIDs, intrinsic renal or hepatic disease, pulmonary embolic disease, hypoalbuminemia, depression or anxiety, bilateral renal artery stenosis, severe anemia, and thyroid disease. We have to rule all of these before concluding it could be a chronic heart failure. Causes of a falsely increased natriuretic peptide. So once you decide it is a heart failure, you check the BNP, natriuretic, that is brain natriuretic peptide. So sometimes it can be falsely increased also. That is when there is structural or functional cardiac disease or any cause including MI. Baseline is increased in females and those with more than 70 years of age. Diabetes mellitus, lung disease including COPD and pulmonary embolism, liver failure, renal impairment, sepsis. So these are the causes of falsely increased brain natriuretic peptide. Either there could be structural or functional cardiac anomalies, or in females it is normally increased in baseline, and those with more than 70 years it's normally increased, and some conditions like diabetes, liver failure, sepsis, renal impairment, lung diseases, example COPD and PE. These are the causes. Causes of falsely decreased natriuretic peptide. So whenever you're diagnosing or suspecting a chronic heart failure or heart failure and you're checking a brain natriuretic peptide, sometimes it can be falsely decreased also in cases like obesity. So in obesity you have to be excessively suspicious about heart failure even if BNP is decreased. When you're already patient is on ACE inhibitors or ARBs or aldosterone antagonists, diuretics, beta blockers. Classification of a heart failure. Left ventricular systolic dysfunction, decreased ventricular ejection fraction on echo, heart failure with preserved ejection fraction, HFpEF, also termed as diastolic dysfunction. The signs and symptoms of heart failure with normal left ventricular ejection fraction on echocardiogram. So these are the two varieties. Other tests to consider. To exclude aggravating factors and other causes of symptoms, exam for the test which you will do is urine analysis, blood tests, FBC, urea electrolytes, creatinine, EGFR, TFT, thyroid function test, FBG and HbA1c, diabetic profile, ECG, chest X-ray, PEFR or spirometry. These are to rule out other causes wherein BNP may be raised. Grading of severity. The New York Heart Association (NIHA) classification is widely used. NIHA Class 1. There is no limitation. Ordinary physical exercise does not cause undue fatigue, dyspnea or palpitations. NIHA Class 2. Slight limitation of physical activity. Comfortable at rest, but ordinary activities result in fatigue, palpitation or dyspnea. NIHA Class 3. Marked limitation of physical activity. Comfortable at rest but less than ordinary activity result in symptoms. NIHA Class 4. Unable to carry out any physical activity without discomfort. Symptoms of heart failure are present even at rest or with increased discomfort with any physical activity. History. Shortness of breath on exertion or orthopnea, PND. Decrease exercise tolerance, lethargy, fatigue, nocturnal cough, may bring up pink froth or have hemoptysis, swelling of the ankles, abdominal discomfort due to liver distension, cerebral symptoms, confusion and dizziness, increase in weight or decrease. Weight is increased or decreased with or minus wasting. Past medical history of MI, atrial fibrillation or increased high BP, wheeze, nausea or anorexia. These are the symptoms in history. And on examination, these are the signs. So increase in respiratory rate plus cyanosis could be there. Pulses alterance, increased pulse rate, third heart sound. Third heart sound is seen in heart failure. Increase in JVP or hepatomegaly. Cardiomegaly, displaced apex beat, right ventricular heave, basal crepitations, plus or minus pleural effusion, and or wheeze. This is seen when you are auscultating. Pitting edema in the ankles. This is a sign of pulmonary. What is that? Sorry. Pedal edema. Ascites. Cachexia and muscle wasting. So, first in the history, when patient comes to you with all this, any of these signs and symptoms, and on examination when you are examining, then what you will do? You will suspect it's a heart failure. So once you are suspecting it's a heart failure, you have to find out whether they had a previous MI. No, in the history they said no previous MI. Then you check serum natriuretic peptides, where to find out whether they actually have a heart failure. So in a heart failure, the BNP will be raised. So BNP is more than 400 picograms per milliliter or 116 picomoles per liter. So these are two values, 400 picograms or 116 picomoles per liter, or NT-proBNP. This is highly specific. NT-proBNP more than 2000 picograms or 236 picomoles. Yes. Refer to be seen in less than 2 weeks for a specialist review plus Doppler echocardiography. So then you will refer for a Doppler and a specialist review within 2 weeks. So if this patient is suspected heart failure and he had a previous MI, then yes, then also you refer to less than 2 weeks specialist review plus Doppler echo. So, and then the specialist will do what is to need to be done further. So in case the BNP is not raised more than 400 picograms or NT-BNP is not raised more than 2000 picograms, it is no. Then in case the BNP is between 100 to 400 picograms or NT-proBNP is 400 to 2000. That is intermediate. Yes. Then refer to be seen less than 6 weeks for specialist review and Doppler echo. Even then you get a Doppler echo and specialist review, but in 6 weeks. And in case the BNP is normal, that is less than 100, or NT-proBNP is less than 400, then heart failure is unlikely. Consider other diagnosis. So BNP is B-type natriuretic peptide and NT-proBNP is N-terminal prohormone of BNP. This is the algorithm for diagnosing heart failure. Management of chronic heart failure. Always look for the underlying cause and treat wherever possible. Review the basis for historical diagnosis and arrange echo to confirm the diagnosis if the diagnosis is in doubt. See, sometimes this patient will come first to you. Sometimes the patient will come and he gives a history of heart failure, and then you have to review the basis of past diagnosis and then arrange an echo to confirm if diagnosis is in doubt. Driving and heart failure. Driving Group 1 license, stop driving and inform the DVLA if severe symptoms of heart failure is present. NIHA grade 4. Group 2 license, inform the DVLA. Can continue driving if mild symptoms, NIHA 1 or 2, and LV ejection fraction is more than 40%. Regular review. This ejection fraction more than 40%. This 40% mark is very important for many of the reasons. One is for NIHA, one is for driving license and DVLA. Regular review. Every 6 months or so, more often as needed. Check clinical state, functional capacity, fluid status, cardiac rhythm, cognitive and nutritional status. Screen for depression, affects more than 40% of the patients. Manage for comorbidities. Medication. Ensure drug record is up to date. Review compliance and side effects. Change if clinical circumstances or best practice alter. Blood UND, urea and electrolytes, creatinine and EGFR to check the kidney function. Non-drug measures. Educate. Educate about the disease, current and expected symptoms, need for treatment. Discuss the prognosis. Support with written information. Discuss ways to make life easier. Example, benefits, mobility aids, blue disability parking badge. Consider referral to social services for assessment of services such as home care. Diet. Adequate calories, decrease in salt, reduce salt, reduce weight if obese, restrict alcohol. Lifestyle measures. Smoking cessation, regular exercise, restrict fluid intake if severe heart failure. Vaccination. Pneumococcal and annual influenza vaccination. So heart failure is one indication for pneumococcal, one of, and annual influenza vaccination. Diuretics. Relieve congestive symptoms or fluid retention in all types of heart failure. Choose a loop diuretic, example furosemide 20 to 40 milligrams or albumetanide 1 to 2 milligrams OD. Add thiazide if continued problems with edema or hypertension. So even though you are using a loop diuretic furosemide, you can add a thiazide diuretic in case of heart failure. Titrate the dose, either increase or decrease according to need. Monitor for decreased potassium and co-treat with amiloride or potassium supplements as needed. So whenever you're treating with furosemide and thiazide, there is a chance of hypokalemia. So in that case, you treat with amiloride or potassium supplements as needed. Amiloride is a potassium sparing diuretic, and then or potassium supplements. First line medication for left ventricular systolic dysfunction. See, left ventricular systolic dysfunction is decreased ejection fraction heart failure. Start all the patients on ACE inhibitors and beta blockers. So whenever there is a pumping problem, you decrease the heart rate. So beta blocker, ACE inhibitor. ACE inhibitor is the first line and beta blocker. Use a clinical judgment to decide which drug to start first. So you can start these two drugs. Either ACE inhibitors you can start first or a beta blocker you can start first, and then add the second one. It's not that you have to choose among these. Start any one first and add the second one, ACE inhibitors. ACE inhibitors improve symptoms, increase the exercise capacity, decrease the progression of the disease, decrease the hospital admissions, and increase survival in symptomatic and asymptomatic patients. See, this is one of the drugs that increase survival in heart failure. Start at a low dose, example Ramiptal 1.25 mg OD, and titrate upwards. Check urea and electrolytes and creatinine before starting an ACE inhibitors. That you know why, right? Because potassium, if it is more than 5, you don't start ACE inhibitors. You need to ask for a specialist advice before starting ACE inhibitors, and creatinine also. At first follow-up creatinine because you need for monitoring. After 2 weeks, you have to check urea and creatinine, electrolytes and creatinine again to check whether it is affecting, it is increased. At first follow-up and after each increased dose, so you have to check urea and electrolytes and creatinine at starting, before starting, in the first follow-up and after each increase in dose, because they are deranged. Use of ARB is not tolerated, if not tolerated. So if whenever you are using an ACE inhibitor and after in the follow-up you see that either the creatinine is more than 30% of the baseline increased, or if your potassium is more than 5.5, you need to stop the ACE inhibitor. So in that case, in case of left ventricular systolic dysfunction, what will you do? You need to add an ARB in case for any reason you have to stop ACE inhibitor which is not tolerated. If neither an ACE inhibitor nor an ARB is tolerated first line, so now second line option is when ARB or ACE inhibitor, both of them are not tolerated. A combination of hydralazine with a nitrate is an alternative in that case for heart failures. So, and then you seek a specialist advice. Beta blockers. Beta blockers, start a beta blocker licensed for heart failure. So, what are the beta blockers licensed for heart failure? Bisoprolol, 1.25 milligrams in the morning in all those with a left ventricular dysfunction, regardless of whether the symptoms persist. Use in start low and go slow manner with assessment of pulse, BP, clinical status after each titration. You check the pulse, the BP and clinical status, whether he is adequately beta blocked or not, blood pressure is controlled or not, and clinical status. Heart failure with preserved ejection fraction, HFpEF. So in this, the pumping is not damaged, but there is diastolic dysfunction. Apart from diuretics, there is no specific treatment for heart failure with preserved ejection fraction. So you only give diuretics. So in both cases of decreased ejection fraction and preserved ejection fraction heart failure, you give diuretics. Therefore, no specific treatment for HFpEF is there. Treat any comorbidities like diabetes, increased BP, ischemic heart disease. Other drugs to consider: anticoagulation if heart failure plus AF is there, atrial fibrillation or a history of thromboembolism, left ventricular aneurysm or intrathoracic thrombus is there. You start anticoagulation. Aspirin 75 to 150 milligrams OD if heart failure plus atherosclerotic arterial disease including coronary heart disease. Statins only if other indications are present. So now you routinely don't prescribe statins in the case of heart failure unless the other indications are present. What are the other indications? When we read statin, we knew one of them which I remember is a 10-year cardiovascular risk, that is Q risk score more than 10%. Amlodipine in heart failure. Treatment for angina. So in case this patient is having heart failure secondary to MI and now he is having angina, as a treatment for angina, you give amlodipine and increase and raised BP. So either if he is having hypertension or angina, you give amlodipine. Avoid verapamil in heart failure. So in heart failure, avoid verapamil and diltiazem as they are both negatively chronotropic. Means they decrease the heart rate, or short-acting dihydropyridine agents. Referral to cardiology. or other suitable specialist. Consider if E is emergency, U is urgent, S is soon, R is routine. So if there is a heart failure unable to be managed at home, it's an emergency. Severe heart failure, it is urgent or soon. Heart failure not controlled by first line medication, urgent, soon or routine. Angina, atrial fibrillation or other symptomatic arrhythmia is there. Even if it's a arrhythmia, it is urgent, soon or routine, but never not emergency. Heart failure due to valve disease or diastolic dysfunction, routine. Comorbidity that may impact heart failure like COPD, renal failure, anemia, thyroid disease, PVD, peripheral vascular disease or urinary frequency, gout. Women, it is routine admission. Women with a heart failure planning pregnancy is routine admission. So only if it is the patient is in heart failure unable to be managed at home, you need to admit the patient in emergency. Otherwise, rest everything is routine or urgent review. So treatment under specialist supervision. Left ventricular systolic dysfunction. When there is left ventricular systolic dysfunction, so first you have given ACE inhibitors, then you have given beta blockers, and both of them are not tolerated, you give them hydralazine or with a nitrate combination. Second line agents include aldosterone antagonist, that is spironolactone. Combination of hydralazine with a nitrate. See, first you as a primary health physician you give ACE inhibitors and beta blockers. When you cannot give both of them, you refer to a specialist supervision. In specialist supervision, the left ventricular systolic dysfunction is there, then aldosterone antagonists are given, that is spironolactone or mineralocorticoid antagonist, receptor agonist. Combination of hydralazine and nitrate. ARBs used in combination with ACE inhibitors or beta blockers. So you have already given ACE inhibitor and beta blocker and still you are prescribing an ARB. Digoxin, an antiarrhythmic and positive inotrope. It is used for worsening or severe heart failure due to left ventricular systolic dysfunction despite first and second line treatment. So first line treatments you have given, now second line treatments for these, and then now digoxin is third line only for heart failure. Previously digoxin was given routinely, but now digoxin is third line only. Only check levels 8 to 12 hours after last dose. This is one of the questions in past medicine. Checking of digoxin plasma levels 8 to 12 hours after the last dose if suspected toxicity or non-adherence. Amiodarone. Amiodarone may be used to treat arrhythmias associated with heart failure. It requires specialist initiation and close monitoring with thyroid function test, liver function test at least every 6 months once established on a maintenance dose. Medical devices. So medical devices you can use in cardiac failure, chronic heart failure is implantable cardioverter defibrillator. May be fitted in patient with a left ventricular dysfunction and previous episodes of ventricular tachycardia or a widened QRS complex on ECG. So these are the two indications. See, definitely they have left ventricular dysfunction with with systolic decreased ejection fraction heart failure. But the another criteria is previous episodes of he must have ventricular tachycardias or a widened QRS complex on ECG before you want to fit a cardioverter defibrillator. Cardiac resynchronization therapy. Considered if severe symptoms are maximal therapy and in sinus rhythm with prolonged QRS complexes. So here the QRS complexes are also prolonged. But patient is not in arrhythmia, he is in sinus rhythm and he is having severe symptoms on maximal therapy, then only cardiac resynchronization therapy is considered. Prognosis. Progressive deterioration to death. Half of them die suddenly, probably due to arrhythmias. Mortality. Mild, moderate heart failure, 20 to 30% mortality in 1 year. Severe heart failure, more than 50% mortality in 1 year. Palliative care, we will see further information as in you can check. So page number 236, pulmonary hypertension and cor pulmonare. Pulmonary hypertension. Normal pulmonary arterial pressure is less than 1/5 of that in systemic circulation. Pulmonary hypertension is defined as pulmonary artery pressure more than 25 millimeters of Hg. It is classified according to cause. So causes of pulmonary hypertension. First is group 1 cause. Pulmonary arterial hypertension is group 1. May be idiopathic or associated with connective tissue disease, mainly scleroderma. So these are pure pulmonary hypertension. Due to either idiopathic cause with connective tissue disease, there's a problem with the connective tissue in the pulmonary artery, or scleroderma. Group 2 causes. This is left heart disease. So when a patient has a left heart disease and severe heart failure, systolic or diastolic valve disease, example mitral stenosis, congenital heart diseases, what happens is there is an increased back pressure in the pulmonary circulation leading to secondary pulmonary hypertension. Okay, so there is a block in the forward circulation, so the backward pressure increases, and then which is translated to the left ventricle, translated to the left atrium, and then back to the pulmonary vessels. So that increases the pulmonary pressure. Group 3, that is lung diseases. So any of the lung diseases, interstitial lung disease, COPD, these all increase the deranged pulmonary vasculature, increasing pulmonary pressure. Group 4, chronic thromboembolic pulmonary hypertension. So you have a pulmonary embolism or sickle cell disease. This causes multiple thrombus in the pulmonary circulation, leading to increased pressure is required to push blood against these thrombi or blocks. So that is why pulmonary pressure is increased. So pulmonary hypertension, group 4. And group 5 is unclear and multifactorial mechanism. So we understood group 1 is pure pulmonary hypertension, group 2 is left ventricular disease, left heart disease, group 3 is lung disease, group 4 is thromboembolism, and group 5 is unclear mechanisms. Cor pulmonare, right heart failure resulting from chronic pulmonary hypertension. See, this is seen in COPD. This is right cor pulmonare, right heart failure resulting from chronic pulmonary hypertension. Diagnosis. Non-specific symptoms often lead to delayed diagnosis. So now when you have a right heart failure, what are the presentations? Fatigue and breathlessness on exertion, plus or minus angina, palpitations and presyncope. Later, as ventricular failure develops, symptoms include peripheral edema, ascites and syncope. So first, initially there will be breathlessness on exertion, plus or minus angina. And later ventricular failure develops, symptoms include peripheral edema, ascites and syncope. Examination. Check for cyanosis, peripheral edema, increased JVP, fourth heart sound, diastolic murmur from pulmonary regurgitation, hepatomegaly, plus or minus ascites, crepitations at the lung bases, plus or minus pleural effusion. So presentation is there of cor pulmonare, and examination, what you have to check first, what is the lung cause? Check for cyanosis. If there is any peripheral edema, if there is increased JVP, if there is a fourth heart sound, see, fourth heart sound, diastolic murmur from pulmonary regurgitation, hepatomegaly or ascites, crepitations at the lung bases plus pleural effusion. Investigations. Chest X-ray, prominent right heart border, enlargement of proximal pulmonary arteries. ECG, if abnormal, there will be a right axis deviation, right? Because there is pulmonary hypertension. So against that high pressure, your right ventricle is has to pump. So your right ventricle hypertrophies. So there is a right axis deviation. Tall peaked P wave in lead 2. Tall peaked P wave in lead 2, or the the lead 2 is the strip we check at the base of the ECG. It's a continuous strip. In that, if you even observe a P wave, normally P wave is not so prominent, but it's a tall peaked P wave, then it is you have to think in lines of cor pulmonare. Dominant R wave in V1. See, V1 you have a very small R wave which increases in size when it goes to V6. So it is supposed to be a normal R wave progression. Slowly it will increase in size from V1 to V6. But if a major R wave or a dominant R wave is in V1, then it is a right axis deviation. T-wave inversion in the anterior leads or right bundle branch block scenario. Right bundle branch block is marrow. M wave in V1 and W wave in V6. So management. Refer to a specialist cardiologist or a chest physician. Whenever you see a case of cor pulmonar, it is not a primary care treatment. You have to refer to a specialist cardiologist or a chest physician. Specialist intervention. They do a Doppler echo used to assess the ventricular function and give an estimate of pulmonary arterial pressures. Right heart catheterization. A direct measure of mean pulmonary arterial pressure confirms the diagnosis and provides information on prognosis and determines the treatment plan. See, for confirmation of diagnosis and providing prognosis, we don't need to do a heart catheterization. But however, since it determines the treatment plan, we have to do a right heart catheterization. Assessment of functional capacity. This is the 6-minute walk test is used to give information about the prognosis. Less than 380 meters at presentation. So 6-minute walk test. If the patient is able to walk only less than 380 meters at presentation, it is associated with poor prognosis. Specialist treatment. Depending on the underlying cause. Treatment is usually through cor pulmonar, treatment is usually through tertiary specialist center and includes first is oxygen therapy for symptomatic relief, diuretic treatment for heart failure, vasodilatation with calcium channel blockers in 10 to 15% of patients who are responsive, anticoagulation. Specific drug therapy, group 1 pulmonary hypertension. So if it's a group 1, that is pure pulmonary hypertension, you give specific treatments. Surgery. Specific drug treatments for group 1 pulmonary hypertension improves the symptoms, delays the disease progression and prolongs survival. Always initiated in specialist centers. Prostanoids. Epoprostenol, iloprost, selexipag. These are the prostanoids. Endothelin receptor antagonists. Bosentan and ambrisentan and macitentan require monthly monitoring with LFTs. Phosphodiesterase inhibitors, sildenafil and tadalafil have been used historically for pulmonary hypertension. Other agents, riociguat. Riociguat causes arterial dilatation by an action on an enzyme that mediates vasomotor effect of nitric oxide on the lungs. So, riociguat. This is another agent for primary pulmonary hypertension. Pulmonary endarterectomy. Treatment of choice for patient with cardiothromboembolic pulmonary hypertension. See, this is group 3. So in this case, you can do pulmonary endarterectomy. The majority can be cured with normalization of pulmonary pressures following surgery. More than 90% patients 5-year survival. Only 90% 5-year survival is there. So it's a very good treatment because it increases the 5-year survival by more than 90%. So cardiothromboembolic pulmonary hypertension, you do pulmonary endarterectomy. Bilateral heart-lung transplantation for those who have severe symptoms despite optimal treatment. 5-year survival following a transplantation is 50 to 60%. Driving and heart failure. We have already read about driving and heart failure. That is NIHA class 4, group 1 drivers. Then you have to stop driving and inform DVLA. And in case of NIHA class group 2 drivers, if it is NIHA class 1 and 2, you can drive, no need to inform DVLA. If ejection fraction is more than 40%, you can drive. But if ejection fraction is less than 40% or NIHA grade 3 and 4 in class 2 drivers, you have to stop driving, inform DVLA. 238 tachycardia. Tachycardia is a heart rate more than 100 beats per minute. It's often felt as palpitations, common and may be an incidental finding. History and examination exclude significant problems in most patients. Driving and arrhythmias. History. Ask about, this we will see in 241. Ask about palpitations. Duration, frequency, pattern of palpitation, rhythm. Ask the patient to tap it out if not present when seen. So the patient will be able to tap it on a table, the rhythm, if it is regular, irregular. We have to try that. Precipitating and relieving factors of palpitations, associated symptoms, whether the specific relieving factors means whether they are associated with any anxiety, work or anything, or whether it is what the patient does to relieve it, or it spontaneously resolves, or is paroxysmal, that we have to find out in history. Associated symptoms: chest pain. Is it associated with chest pain, collapse, funny turns, sweating, breathlessness, or hyperventilation? Past history: previous episodes, heart disease, thyroid disease, family history, any cardiac rhythm disorders, sudden death, lifestyle history, drug history, caffeine or alcohol intake and smoking. Occupation: arrhythmias may affect driving or work. Red flag symptoms. Red flag symptoms in case of arrhythmias. These are palpitation, tachycardia, pre-existing cardiovascular disease, family history of syncope, arrhythmia or sudden death, arrhythmia associated with falls or syncope. Examination. General examination for anemia, thyrotoxicosis, anything that can cause palpitation like anemia, thyrotoxicosis, anxiety, other systemic disease. Cardiovascular examination: heart size, pulse, rhythm, JVP, blood pressure, heart sounds, murmurs, evidence of left ventricular failure. Investigations. Resting ECG is all that is needed for many patients. Consider further investigations if ECG is abnormal or after concerning features are present like syncope is there, breathlessness is there, prolonged episodes are there. Then you need to consider other investigations like thyroid function test, blood tests like thyroid function test, FBC, ESR, CRP, urea electrolytes, sugar, FBG, fasting blood sugar, and HbA1c, calcium and albumin, ambulatory ECG or cardiac memo, Holter monitoring, echo, if less than 50 years of age or murmur or heart failure is detected. Exercise tolerance test, if it is exercise related. Ventricular tachycardias. Ventricular tachycardias, see, they arise from the ventricle. These are the beats arising from the ventricle, right? So they are broad, more than 3 small squares. QRS complexes. So whenever you have a broad QRS complex, you have to check what is the heart rate, first thing, and QRS complexes at a rate more than 100 beats per minute on ECG. Admit as a blue light emergency. Meanwhile, give oxygen if available plus or minus 100 milligrams IV lidocaine. So ventricular tachycardia is very serious arrhythmia. So you need to diagnose it very early. So QRS complexes at rate more than 100 beats per minute on ECG. Admit as a blue light emergency. Meanwhile, give oxygen and if available, give 100 milligrams IV lidocaine. If no pulse, see pulse. If there's pulseless ventricular tachycardia, treat as ventricular fibrillation cardiac arrest. So we have to treat as a cardiac arrest or ventricular fibrillation if there is no pulse. Pulseless VT. If recurrent VT may require surgery, insertion of a pacemaker or implantable cardioverter defibrillator. So if there is recurrent ventricular tachycardias, you need to insert a pacemaker or an implantable cardioverter defibrillator. Ventricular ectopic beats. Additional broad QRS complexes without P waves superimposed on regular sinus rhythm is very common, usually no significance, rarely a presenting feature of ventricular myocarditis, viral myocarditis, frequent ectopics, more than 100 per hour on ECG, urgent cardiology referral. So you do a Holter monitoring and then you see there is frequent ectopics more than 100 per hour, more than 100 ectopics in an hour on ECG. Then you refer urgently to cardiology. If R on T phenomenon on ECG, rarely ectopics can lead to ventricular fibrillation, particularly if they coincide with the T wave of a preceding beat or an R on T phenomenon. So this is seen on the ECG. So if you see this and you suspect, admit if this occurs more than 10 times per minute on an ECG. So after MI, associated with an increased mortality. VT of ventricular ectopics after an MI associated with increased mortality, so refer to cardiology. No sinister features on ECG. Explain the benign nature. Advise avoidance of caffeine, alcohol, smoking, and fatigue. Beta blockers can be helpful if unable to tolerate ectopics despite reassurance. Long QT syndrome, LQTS. ECG shows prolonged QT interval. Heart is structurally normal, associated with ventricular arrhythmias, which may lead to syncope, sudden death, often triggered by an excitement or exercise. If inherited, may be an autosomal dominant or recessive. Refer any patient with a family history of sudden cardiac death for specialist assessment. Antenatal screening is possible for long QT syndrome. Brugada syndrome particularly affects people of Southeast Asian origin, males very much more than females. Autosomal dominant inheritance, but family history is only present in 50% of the cases. Results in syncope or sudden death, usually less than 45 years of age, due to ventricular arrhythmias, often at night. ECG shows Brugada sign. What is Brugada sign? It's a code ST. It's a code ST and increase with a height more than 2 millimeters. Code ST elevation of more than 2 millimeters in V1 or V2. Followed by a negative T wave, but may be transient or absent. Treatment is with ICD, implantable cardioverter defibrillator. Arrange same-day cardiology review if suspected. See, for a patient for a male patient, up to 2 millimeters of ST elevation is fine, is normal. You cannot take it as ST elevation. So more than 2 millimeters is there, then only it is ST elevated, and here in Brugada sign it is code ST elevation, V1, and in V1 and V2 followed by negative T wave. So wherever we find that ECG, we will discuss again. Paroxysmal supraventricular tachycardia or SVT is a narrow QRS complex tachycardia with a regular rate more than 100 beats per minute on ECG. So it's a narrow QRS complex and rate is also increased. If seen during an attack, get an ECG if possible. Try a carotid sinus massage unless he is an elderly, because he might have a carotid thrombus might be there, which might embolize. IHD, ischemic heart disease, digoxin toxicity, carotid bruit is present, or a history of TIAs is present. So in these cases you have to avoid carotid sinus massage, but if you are seeing in a young patient or without any of these symptoms, the Valsalva, you need to try the carotid sinus massage for SVT, or the Valsalva maneuver, ask the patient to do the Valsalva maneuver, or ice on the face, especially effective in children. If in a child you are finding, you can put ice on the face or a cold water. Admit as an emergency if attack continues. If attack terminates or not seen during an attack. So SVT may be diagnosed on a 12-lead resting ECG or a 24-hour ECG cardiac memo. Refer to cardiology for assessment and initiation of treatment urgently if chest pain, dizziness or breathlessness is present during the attacks. If the patient is complaining, you have these palpitations, because SVT, the patient will only know that his heart rate is increased. So he has palpitations, that will be the symptom. So if he has chest pain, dizziness or breathlessness during an attack, you need to refer to a cardiology. Exclude if ECGs, include if ECG is available. Ongoing care. Avoid caffeine, alcohol, smoking. Treatment. Catheter ablation or drug therapy. Sotalol, diltiazem, verapamil or flecainide. See, sotalol, diltiazem, verapamil or flecainide are the treatment for SVT. Wolff-Parkinson-White syndrome. A congenital accessory conduction pathway is present between the atrium and the ventricle bundle of Kent. It predisposes to SVT and atrial fibrillation. ECG shows a short PR interval followed by a slurred upstroke, that is a delta wave. See, the PR interval is shortened and there is a slurred upstroke for the R wave. So there is a delta wave into the QRS complex. Refer to cardiology. Treatment is with antiarrhythmics if there is an SVT. See, WPW can present either with an SVT or AF. So if there is an SVT, you need to give verapamil. And if there is atrial fibrillation, you need to give amiodarone or a DC shock, plus or minus ablation of the accessory path. Sinus tachycardia. Consider infection. See, it is not any pathological tachycardia, but only sinus tachycardia. Consider if there is any infection, pain, MI, shock, exercise induced, emotion induced anxiety, heart failure causing increased heart rate, thyrotoxicosis or drugs. These are the drugs you need to rule out when there is a normal ECG and only there is tachycardia. Inappropriate sinus tachycardia is a diagnosis of exclusion. So you have to rule out everything else like MI, shock, exercise, emotions, heart failure, thyrotoxicosis, drugs. Other causes you have to exclude inappropriate for diagnosing as inappropriate sinus tachycardia. Persistent tachycardia of more than 95 beats per minute averaged over 24 hours with a nighttime rate dipping can result in palpitations and breathlessness, fatigue, exercise intolerance and syncope or presyncope. Cause is unknown. Treatment if needed with beta blockers or a rate limiting calcium channel blockers. Postural tachycardia syndrome or POTS. Change from lying to standing causes an exaggerated increase in pulse rate more than 30 beats per minute, more common in females than males, may be a family history. Average age of presentation is 20 years. Suspect if palpitations are present, weakness is there or syncope or presyncope, but no decrease in BP on standing. So, on standing there is no reduced decrease in BP, but on standing there is increase in pulse rate more than 30 beats per minute. You have to suspect POTS. Diagnosis is confirmed by table testing. Treatments include behavioral modification and drugs, example beta blockers. Cause is unknown, may spontaneously remit. Atrial fibrillation or flutter, we will see further on. No tachycardia and no ECG abnormalities. Then reassure. Explore the possibility of anxiety disorder. So whenever the patient comes with palpitations and in the ECG you see no tachycardia or no ECG abnormalities, patient is complaining of palpitations, then reassure. Explore the possibility of anxiety disorder. Anxiety can also cause tachycardia. That's all for today. From page number 240 we will continue tomorrow. Thank you friends. Have a good day.